Why, hello there. All right, so today's discussion or lecture is going to be over stress and cancer. So, first thing we want to look at is the HPA or hypothalamus pituitary axis. So, our adrenal gland is mounted on top of the kidneys. Okay, so we have two adrenal glands, two kidneys. And it's controlled in two different ways. So, the cortex, which has three layers, is controlled through hormones. So hormones release, they act on it, causing the adrenal gland to release something else. Okay. The medulla is controlled by a nerve signal. The reason being the center of the adrenal gland is what produces norepinephrine. So during like fight or flight, we need that direct response fast so that we can flood that into the bloodstream and we can bring all cells online for fight or flight. Okay? So whenever you're looking at endocrine topics, this system here is really the easiest way to learn it. Hypothalamus releases a releasing hormone. It's connected directly to the pituitary gland. So we don't see these releasing hormones. Okay? You can't see them in the bloodstream, can't measure them. The pituitary then responds and releases a hormone that will act on a tissue or another organ. And as those levels saturate the bloodstream, the pituitary gets turned off, and so does the hypothalamus. This is negative feedback. Okay? If the levels are low, there is no negative feedback, and so we start the process. Okay? So cortisol is considered the stress hormone. We can release cortisol under physical stress or emotional stress. Okay? Lots of issues here. We see, high cortisol levels typically in obesity. You're stressing the body with the sleep deprivation, a causation of hypertension. Okay, so the problem with cortisol, glucocorticoids, making the body less responsive to insulin. So what this does is encourages fat depositing, encourages diabetes. Okay. Decreased capillary permeability, decreased inflammation. So that's why we use it when someone has an inflammatory situation. They can prescribe some cortisol. Okay, it has a negative impact on immunity. It can decrease immunity's response. So that's why it can be used kind of as an immunosuppressant. But big thing, inflammation suppressant. So it's like prednisone, for example. Okay. Medrol pack, all that good stuff. Metabolic syndrome. So this is the trifecta. You're going to see this. This is just constant. Okay. Abdominal fat. They have this increased waist size. High blood pressure, high LDL, okay, and diabetes. All of this is just synced together. So this is very common, especially in the U.S. population. If they have high cholesterol, they have high blood pressure, they have diabetes. It almost goes hand in hand in hand. All right. And one of the biggest defining factors is waist size. All right. A couple terms here. So neoplasm, that's just a tumor. Benign, those are non-malignant tumors. Those are kind of the safe tumors that we don't bother with. And really the reason is they obey the order of don't push on others, essentially. Your cells are able to communicate. When your cells bump into each other, they release communicators to say there's no more room, stop growing. Benign tumors obey that. Malignant, on the other hand, don't. So they are invasive. So that's why it's like this jagged edge. It's showing that it's like poking into the other tissue. Malignants are going to metastasize given time. Okay? If the body can survive long enough. Typically, benign tumors do not become malignant. That's pretty darn rare. Okay? There's a couple out there, but it's pretty rare. And even the occurrence then on those is low. All right, squamous cell carcinoma. So this guy here, there is these excessive growths in here. So we start to see these atypical nuclei, these abnormal looking cells, and that's how we identify that. Osteosarcoma, so this is of the bone, okay? So you can see this like kind of sunbursting out. So the periosteum is the covering on the bone, and that's where that started in this image. All right, teratomas or dermoid cysts. These guys are wild. They are benign, okay? I put in here typically not malignant, but they're benign. So they're from like germ cells or stem cell lineages that are packed in there that just kind of started differentiating. So if you look, I mean, it's got teeth, it's got hair, all kinds of tissue. And that's what that image, you know, down here is that on X-ray. Usually you just randomly find it. I had a student, was it last semester? Ended up having one, accidental discovery. Okay. Usually don't do anything about it unless it's causing problems. Okay, this is like where they got the whole concept, I believe, where it's like, oh, you had a twin and you like ate it as a fetus. I think that's where that term came from. Okay, anaplasia versus dysplasia. Anaplasia bad, real bad. Okay, undifferentiated. When you have this, when the cells don't mature and look like normal cells, that is a problem. Dysplasia, we're starting to change, okay? We might be able to come back from it, right? And then carcinoma, that just means rising from epithelial tissue. So you have your normal here. You can see all the nice cell structures, all smooth in here. This is a benign. You can see it's over-proliferated, but it's not pushing its borders. Well-differentiated malignant, these are more treatable typically. The cells are some type of mature cell, just in the wrong place, essentially. Poorly differentiated, this is bad. You can see there's no rhyme or reason to the structure, and look, it's invading. You can tell it's starting to try and invade the surrounding tissue. Anaplastic, there's no form, and it is just everywhere. Okay? And there's another benign there. There we go. Carcinoma in situ. So the big point here is it doesn't make it past the basement membrane. So right there, that's good. That's treatable, okay? This is very close to not being treatable. This is where we get into problems. So you can see it's invaded the submucosa. It's in the submucosa, and there's vessels in the submucosa. So the problem there is malignancy. Now it is going to travel the highway through your body, land somewhere, and start growing. So this is like where you start talking about, you know, a patient's in remission for 5 years. Well, the reason we say 5 years is hopefully we got all of this. If we didn't, if we lost like one little cell in here, it may take 5 years to reappear, to grow big enough for us to see it or see symptoms, stuff like that. Same thing with if a cell dropped into your bloodstream and it's somewhere else, it may take us 5 years to see it. Once you cross over that, you're cancer-free. Okay, so that's what the whole terminology of remission is. All right. Tumor grading, so you guys are responsible for knowing this. We could give you like some descriptions, and I'll show you on the next couple slides, and you may have to grade, okay? So Nottingham is what they use for breast cancer, Gleason for prostate cancer, okay? And the reason you grade is to place the patient to know where they are and know what treatment they are going to need, okay? So here, for example, you know, well differentiated, appears normal, not aggressive, that's a grade 1. That's very, like, treatable. And then as it goes further along, you can see we lose all structure in here. So here you can see the glands, okay? Here there's an overproduction. Here it's just wildly overproduced to where they're not even visible. They're crushing each other. So how you do grading is on the TNM staging system. And what that refers to is like tumor, okay? node involvement, metastatic spread. So it's like, how big is the tumor in the breast tissue, for example? How many nodes are involved beyond that? And is it somewhere else in the body already? So how they grade is all these points here. So like G1, well differentiated, low grade, okay, so on and so on. All right, so adenocarcinoma. So this is looking at the colon, and just in those glands in there. Leukemia, this is an excessive amount of white blood cells. They're non-functional, usually, okay. Hodgkin's lymphoma, these are Reed-Sternberg cells. See these double nuclei? So that's unique to Hodgkin's lymphoma. Tumor markers. So tumor markers are, something we're working on still. We don't 100% know all the tumor markers. So if you've done something like, what is it? 23andMe, I believe. Okay. Any of those things where you send off your DNA and get it, figure out your family history, that kind of thing, your history. Part of that research is looking for tumor markers. You submit, that's part of it. You submit that data will be sent off to like universities, stuff and whatnot, and do research on that data and try and identify these tumor markers. That's in part how we do identify them. Tumor markers does not mean you'll have the tumor or the cancer. It just means increased risk for the most part. We can also use them as measuring tools. So, for example, like PSA. This is for males. It can be an indicator of prostate cancer or benign prostate hyperplasia. It's not, if we see it, immediately cancer. Okay, not necessarily. Like, we do need to investigate further. But let's say someone did have prostate cancer. We treat it, we measure their PSA, and then we monitor it and trend it. If it starts going up all of a sudden again, the cancer's back. Okay, so we can use it in that fashion, for example. The chart down here is referencing PSA levels, different populations, age groups, and you can see it goes up in every age group because pretty much an inevitable for every single male is they'll have BPH. Okay. HER2, so this is a growth factor receptor on like breast tissue, so we can use this to target it and treat it. And you may have seen commercials where they say like, oh, your breast tissue is positive, HER2 positive or something. Like, that's what they're talking about, is treating that. The problem is like certain breast cancers are like triple negative. There are no receptors on them. There's really no way to treat them. Okay. CA125, ovarian cancer. Bench-Jones, this is multiple myeloma. This is a direct indicator. That one means you have multiple myeloma. BRCA, there's BRCA 1 and 2. So these are big identifiers for if patients have them for breast cancer. So this is why they ask, do you have any family history of cancer? And we start to identify from there that you may have one of these genes. So, like if as a female, if your mom and your sister and your aunt all had breast cancer, you're probably going to have breast cancer. There's a high chance that you have that BRCA gene. Okay. So here is the breakdown, that TNM. And it shows you like the different sizes, so you guys need to know this chart, okay? So I could give you this information like that, and you would have to tell me what grade or where does it land, okay? Or identify each category, something like that. Okay, so here, more information for you. You guys can run through that. It's the same thing, just different style chart. Oncogenes and proto-oncogenes. Oncogenes are cancer genes. Proto-oncogenes regulate this growth. They can be converted into oncogenes. Okay? So certain things can cause a conversion. It could be random, or it could be a mutagen, okay? Like smoking, drinking, something like that. Sunlight cause that mutation and activate it, or even viruses. Okay? So oncogenes, this RAS, the HER2, tumor suppressor genes, retinoblastoma or RB, P53, these, when they go unregulated, like if they're mutated, the first one, retinoblastoma, is pretty neat. This one usually happens in children, and it's discovered when you take a picture of them with your flash on, and you'll see it in their eye in the picture. You'll see the distortion and the tumor in there. The pupil of your eye is actually a hole, and so that's why you get red eye, because you think about the eye as a globe. There's a hole, the back has blood vessels, the light bounces out, red. And so that's where red eye comes from. So I remember years ago, I had an older student, and she told me her husband discovered their child had retinoblastoma in that fashion, had taken a picture of the kid and caught it, and they got it treated. I'm not familiar with the treatment. I don't necessarily know it needs to go all the way to like eye removal. I'm pretty sure they can go in there and yank that little bugger out. But yeah, P53, this is a regulator. This is a checkpoint, in mitosis. Both of these are RB and P53. When this one gets mutated, it's genetic. And when it happens, they have multiple types of cancer starting in like puberty age. It starts going out of control. Like by 20, they probably had 3-4 cancers of different types. It was an interesting story. A few years back, there was this lady local here. She was on the local news, and she had that disease. It's called Law-Fremeneux syndrome, or syndrome, I guess. And she was on the news. Her and her partner had a kid. Luckily, she didn't pass that on to the child. Okay. For the second child, she decided she didn't want to play, risk it. And so she went down to Emory, and they basically extracted eggs from her. They looked at the genes. They figured out which gene or which egg did not have that P53 mutation that would be passed on. Fertilized it from her partner, implanted again. Safe child. Eliminated that from the gene pool. So that's pretty neat. But yeah, she was like in her 20s, and I forget how many times she had already had cancer. So they constantly have to get scanned and tested and just be on top of it. So that's where this gene is chromosome 17. It plays a role in lots of cancers. Okay? Since it's a checkpoint in mitosis, it's catching errors. If there's an error, we stop the replication, and if it's mutated, you have random cells just replicating uncontrollably, potentially. Telomerase. So that's what maintains the ends of your DNA, the telomeres. Every time your cells divide, they shorten. We lose little bits, and eventually the DNA is not viable for that cell lineage, and it dies off. Okay? That's aging in short. Cancer cells. They can activate telomerase like wildfire and maintain the telomeres. And that's why they can replicate indefinitely, essentially. That right there, telomerase, that's the fountain of youth, if you will. If someone develops that and you can maintain your DNA structure every time you replicate, you really won't age. When we have these guys that are just estrogen receptor negative or HER2 receptor negative, it is hard to treat. Okay, so like here, we have this estrogen receptor, we have this drug tamoxifen, we can attach it to it and disable the cell proliferation. We inhibit it. But if it's missing, we can't turn it off. So really, your only option is like radiation at that point, or surgical extraction. So sometimes that's what you have to do. That's where like a mastectomy comes into play. A mastectomy, they just remove the breast tissue. Some women will opt to remove both because the lymph nodes communicate side to side, or the lymphatics. And so it could be in the other breast tissue. You're already under anesthesia. They just commit to doing both. Okay. And then afterwards, they do like implants and whatnot to give them normal structure again. The problem is because the lymphatics in there are so proliferant, they communicate out. So a lot of times they'll have metastasis to the lymph nodes in the armpit and the axilla. And so they will have to remove those as well. And so that's a radical mastectomy is what it's called. The problem with that is your lymphatics help drain interstitial fluid. So in your arm, you have your vessels and it's pushing hydrostatic pressure out, and there's osmotic oncotic pull back in, but they're not even. So there's more pressure pushed into the tissue so we can perfuse the tissue. Well, the extra fluid in there, some drains from veins, but it's not all of it. That's where lymphatics come into play in this situation, and they drain that excess. Well, if you remove something here, the rest of the arm is not going to drain, so they get edema. So they'll have like this one enlarged arm. So if you've ever seen like a woman walking around and she has like a compression sleeve down her whole arm, that's why. They're increasing hydrostatic pressure of the interstitium to push it back into the vessels, into the veins, to encourage it. That's the reason they're wearing that. All right. Cancers. So a lot of times they don't have vessels going to them, or not enough at least, and they want to replicate. So what they do is they go and ferment. They don't have a problem doing fermenting. They consume glucose on an insanely high rate. Okay? Remember, fermentation, for every glucose molecule, you get 2 ATP. For cellular respiration, for every glucose molecule, you get 32 to 38 ATP. Okay? This image says 36 approximately. So the problem with that is you're consuming nutrition eventually. Your body will start to break down protein, fat to supply this demand because you're starving all your cells, because this is just eating it all. This is where you start to see that rapid weight loss. Okay? So the Warburg effect. For some reason, cancer cells just prefer fermentation. Here, this is just showing lung cancer. So what they did is fluorodeoxyglucose, glucose. These cells sucked it in, okay? And that's why we can see it. Everything that's using glucose, brain, heart, and then it's being excreted out the kidneys into the bladder. So that's why you see those other areas lit up. But that's how they can identify these tumors, because they have such high metabolic rates. They are consuming this at such a high rate, it is being attracted to there, okay? And like sitting in there because it's irradiated, and that's why we can image it. Stromal cells. So these cells, they're recruited by the cancer cells, okay? And they put them to work. And what they do is they get them to secrete things like growth factor. VEGF, for example. They can, essentially what they're doing is stimulating the body to do what it needs. So like neoangiogenesis. It wants blood vessels to grow to it and feed it. And so there is this whole part that you're battling with all these growth factors on top of the cancer itself. All right. The problem with cancer is it's your cells. Some mutation happened. Somewhere along the line, somehow a mutation happened, genetic, whatever, mutagen. How does your body know that that cell is bad now? It can't unless the cell tells it. So here, this is normal. We have a bad cell. He presents on MHC and tells the cell, I'm bad. Okay? So the T cell kills it. That's what should happen. Here's the problem. Cancer. We don't generate the antigen. So we have the MHC, no antigen to mount into it. We can't make the MHC. It turns it off. We have the antigen, we just can't present it. Or my favorite, it can release immunosuppressants. So it turns off the T cell. T cell identifies it, wants to kill it, but it goes, no, I'm good. You don't need to do that. Don't worry about me. I'm bringing my friends, right? So that's the problem, is how do we stop this? How do we stop, all three of these situations? If you do, your own body will get rid of the cancer because it's going to identify it, it's bad, and it's going to destroy it. That's the science of curing cancer in reality. And it would be the most simplistic way. The problem right now is when you talk about like dealing with cancer, well, you do radiation. Radiation damages the DNA. Well, it doesn't get just the cancer cells potentially. So one side effect of radiation therapy to treat cancer is a different cancer down the road. Okay. The medications are getting a lot better. You know, they used to be real bad. The vomiting, the hair loss, all of that. Yeah, does some of that still happen? Certain meds, yes, but they're better because they can target receptors. So they tend not to affect other parts of the body. Okay. So they're getting better with them, but it's not 100%. So stem cells, and that's really the problem. If it's a genetic defect in the stem cell, I have to kill off all the cells that it made plus that cell. Because if I don't get it, eventually it comes back. So this is why when you talk about like chemotherapy, stuff like that, you know, the hair falling out, you're affecting mitosis. That's really what it is. The nails stop growing, their skin cracks. You're affecting mitosis, and those are all rapidly mitotic activity, or they have rapid mitotic activity in those cells, and that's why hair falls out and whatnot. Clonal expansion, I mean, that's just the cells cloning itself, and it's a multiplier. One cell becomes two becomes four, and so on and so on, and so it can grow very rapidly, especially the bigger it gets. The more of these cells you have, that exponential growth is even faster. So it's like, it's interesting. You watch someone with cancer, and in the beginning, it's like, oh, you're not doing too bad, not doing too bad. And then you get about midway, and it starts to speed up. And it just spirals out of control very rapidly towards the end. And that's why sometimes, you know, people go in and they're like, I was just told, you know, I have a couple months to live. I just felt a little sick. They were sick for quite some time. And now it's getting to that point where the symptoms are, there is a big mass of cells replicating, cloning, like wildfire. Okay? So that's why, you know, it's important you do things like your yearly checkups. If you don't feel right, something feels off, go get checked out. You'd be surprised. You know, one of the biggest issues here, why cancer rates are really high in the U.S., is people are not proactive about preventative medicine. I mean, you tell a lot of people, I won't say most people, a lot of people, at 45, you need to go get a colonoscopy, and they'll be like, nah, I'm good. If I feel bad, I'll get it. If something's wrong, I'll get it. You won't know, okay? Colonoscopy, they go in there and they see, you know, these polyps, they remove it, that's the end of it. You're good, okay? No cancer. Mammograms, pap smears, all of that, and just general blood work can all identify cancers. My wife used to work with another pharmacist, didn't feel well, kept on ignoring it, collapsed in the hospital one day. Took her down to the ER, did blood work. The second they saw the blood work, leukemia. And she's been battling that for right before the pandemic hit. And she's not winning at this point. She comes back a little and then nosedives again. It's a difficult situation, but she, to the point where she had graft versus host disease. So she rejected the first bone marrow transplant. The second bone marrow transplant she took, the bone marrow, the white blood cells decided that her lungs were foreign and attacked them and destroyed them. She had to get a double lung transplant. Just slowly tearing her apart, unfortunately. So, 'tis life, right? Metastasis, so here's the problem. Tumor grows, gets into the bloodstream or lymphatics. Highway around the body. You can get these embolisms, so these momentary clots even. Those are TIAs, transient ischemic attacks. These random pieces of paralysis, these stroke symptoms, and they just spontaneously disappear, a few minutes. Those are little mini clots happening, and then the pressure builds behind them, and they blow through in a vessel. Okay? Eventually, they get into a capillary bed where it's real tiny, and they stick. Then they migrate out, potentially, okay? And they start growing. That's your metastasis. Infectious causes, there's quite a few out there. So like H. pylori, which causes ulcers, can cause tumors. Hep B, Hep C more than Hep B. And that's kind of a big concern. There's a decent amount of people out there with Hep B. We do vaccinate from day one of life. That's important. Not only can you develop cirrhosis and have full-blown liver failure, and you cannot survive that. The cancer side of it. Hep C, there's no cure for Hep B. Hep C, a cure came out recently. It's 21 pills, and I think it was like $25,000 or $30,000 for 21 pills. And it has like some insanely high cure rate. Like Harvoni is one of those ones that came out recently. The reason that's of concern is in the baby boomer generation, there is an incredibly high amount of Hep C. And the reason being, we didn't know it existed. We were reusing needles for vaccinations. Sounds silly, okay? Sounds silly, but we just didn't have knowledge. Back then, we didn't know. And it's crazy, like, I was watching like a documentary thing about Ebola, is what it was. And it was the same scenario. And that's why it just spiraled out of control. They didn't realize, there was these diseases, and they were transmitting it by giving vaccinations. Hep C is more common with like prison tattoos. That's a lot of times where you see it. And so that's sometimes a question when you go to a doctor's office if you've ever been to prison. That's what they were alluding to check. Okay? HPV, human papillomavirus, so that can cause cervical cancer, esophageal, rectal, penile. And so that's why the HPV vaccination is approved for women and men. EBV, Epstein-Barr virus, that's what causes mono. We don't really have the strain of EBV here in the States. It's usually that specific strain that causes cancer. That's usually seen over in Africa, but it causes this tumor of the jaw. Okay. You got to listen to your body. If you are abnormally fatigued, that could be a sign, right? You're not resting, and the reason it's the consumption of the nutrients. This pain that won't go away with rest. That's a big sign. Okay. Like pancreatic cancer, lower back pain that doesn't go away with rest. And like it gets men majority of the time because they're like, oh yeah, I was just, working in the yard doing whatever, and that's why my back pain's there. It's normal. And ignore. By the time they go get imaged, it's in the bone. And that's a problem. Okay, it's like in the spine. Cells not functioning properly, so we can see all kinds of issues there. You're getting infections because your white blood cells aren't functioning properly. And then there's paraneoplastic syndrome. So paraneoplastic syndrome is a tumor in the lungs that secretes hormones. So it's pretty wild. Like ADH, for example, it'll release ADH and they're just holding on to water, and it's diluting all their electrolytes. They could be having like seizures, stuff like that, not even know that's the causation, is that they have a tumor in their lungs. Okay? Growth hormone, all kinds of hormones can be released. Cancer risks, the biggest is tobacco. Okay? We can put vapes in there, your superheating metal, cotton, whatever stuff in there, fluid, not wise. Okay? Alcohol, when you combine the two, it's like an exponential increase, especially for like esophageal cancer. Infections, like we mentioned, occupational hazards. We're getting better about that. Yeah, back in the day, attendants at gas stations. I think up north they still have them. So they're just constantly getting gas on their hands, and that causes cancer, like leukemias. Exposure to different things. So like there's like pharmaceuticals, for example, pharmacists can only work 10 years in chemo to generate like all the chemo drugs, because their risk of developing cancer just starts to increase very rapidly at that point. So those radioactive chemicals, right? And epigenetics. So epigenetics is these traits that are passed on cell to cell. I believe we talked about them in methylation, so that's we're turning off. The problem is when it unmethylates. Some mutagen, a proto-oncogene, something like that, turns it off. This now will transcribe. This protein will transcribe. The cell goes active on something else it shouldn't be doing. It becomes an abnormal cell, abnormal lineage. So that's the other part of curing cancer, is how do you remethylate cells that shouldn't be unmethylated, that portion of their DNA specifically. All right.